Aloha! Welcome to our Neuro Network. We are more than a podcast. We are a scholarly network of compassion, wisdom, and support for those living with acute, chronic, and complex neurological conditions, including neurometabolic, cerebral, venous, and cerebral spinal fluid variations. Our Neuro Network is where science meets soul, a place where we gather as one to honor the human experience, restore balance, and nurture hope. This volunteer-driven humanitarian endeavor is made possible by our Neuro Network and sustained by listeners like you. Together, we create a space for storytelling, active listening, and mentorship, weaving compassion, holistic wisdom, and evidence-based insight into every episode. Our mission is simple, yet profound: to bring honor, promote homeostasis, and inspire hope. I am your host, Tiffany Hoke, a doctor of nursing practice, board-certified adult gerontology, acute care nurse practitioner, stroke-certified registered nurse, and certified neuroscience registered nurse, with over 2 decades of professional experience and 4 decades of personal experience. You see, for me, this podcast is both professional and deeply personal. I'm not only a healthcare provider, I am a patient and family member affected by these conditions. I found answers for my family and I, and transformed my quality of life with the help of my medical team, family, and support network. Now, I wish to share my experience and knowledge with you as we connect and learn from others. Thank you for joining us. We know you love our show. We love you. You know, I recorded an original episode some months ago, and I was not satisfied with it because it was a bit too scientific and formal. And as I listened to it, it lacked the warmth, it lacked the story, it lacked the reason. So this first episode is not scripted. Yeah. Our episodes will be unscripted for the most part, other than notes. I want this podcast to be real, human, and a platform that we share upon, that we talk story, as we say in Hawaii. When we talk to one another, our friends, we get together, we say we're talking story. And I want the same feeling to permeate throughout our show. So I thought there's no better way to honor that than to actually share with you my story, who I am, what happened to me, my family, and why we're here for you. So I could start off by telling you my credentials, but I've learned that the letters behind your name do not matter so much, but it's the way you treat people and the energy you carry, your intention. It's your story. So I'm going to start from the beginning, and we'll see how long this episode gets. uh, I am 41 years old, and I live in Honolulu, Hawaii. I was not born here, as you can tell from this accent. I was born in Jonesboro, Arkansas. I did not think that I would end up in healthcare initially. I thought I would be a writer or a musician, a poet. You know, I'm grateful that I still enjoy those things because it keeps me human, but I'm also very grateful that my journey took the course it did and that I am a nurse practitioner. And I think my story will illustrate why. I first became interested in neuroscience as a young adult because my mother was affected by a neurological illness. There was much we did not know then. We knew, though, that she had a headache and migraine disorder, that she had what is called a subarachnoid cyst or a brain cyst in the temporal lobe of her brain, in the left lateral ventricle. That's the hole in the brain where spinal fluid is contained on the left side. And the temporal lobe is responsible for impulse control, mood, so many things. It connects to our limbic system. It's near our brainstem. Seizures can arise from the temporal lobe, so it can cause a lot of symptoms. We knew she had that brain cyst, and we knew that she had seizures called temporal lobe epilepsy, that originated from the area of her brain that was compressed by this brain cyst because it did appear to be compressive. It had what we call a mass effect, meaning that it affected its mass upon the local tissue, brain tissue surrounding it. Uh, I cannot remember a time that I did not see my mother experience nearly daily pain or the effects of her illness. My earliest memories regarding this were of me, 4 years old sometimes, cooking her breakfast, bring it to her in bed, hoping that she could eat, worrying about her sleeping for days. She would hate for me to see her like that. I didn't understand why then, like I do now. I remember her saying, "No, no, get away. I don't want you to see me like this. You deserve a better mother." And I would think, how could this woman whom I love say such a thing? There could be no better mother. Because in my childlike brain, all I saw was someone I loved suffering. And I knew that it was not of their own accord. I could see it in so many ways. You know, a child, there's so much we don't know, but there are things that we know immediately. And that was the truth of the situation. And I just wanted to help her. I wanted to ease her suffering, because I cherished those moments where her suffering would pause. And she was such a brilliant, beautiful light. She was so funny and intelligent and humorous. And in her best of states, she brought so much light and joy to everyone around her that it was so very easy to love her and so very easy to miss her when that person was in pain and hiding, sleeping, searching for answers. Because there was a night and day difference. And I learned early on that it was a cycle. And I learned things that many children don't get the opportunity to learn. I consider it an opportunity and a privilege to be her daughter and to have learned what I've learned. It was not always easy to see someone you love suffer, but it also gave me the knowledge and inspiration that fuels what I do today. And I'm so very grateful for what I do because I feel as if my life is very beautiful and blessed, and that the work I do is very sacred and important. So this story, everything I share with you, please know it is not a tragedy, that it is a story of hope and inspiration. And if you hear my voice cracking, know that it's because it means so very much to me. It is emotional, but there's also a neuroanatomical reason because our vagus nerve innervates our vocal cords. And if you have had vagal nerve issues, you may have dystonia or spasms of the vocal cords causing spasmodic dysphonia. So here you go, folks, with a prime example of I'm going to tell you everything, the emotions behind it, but also the neuroanatomy behind it, and explain to you everything in hopes that it may enlighten you and that we can enlighten one another as we learn and grow. And that's how we'll make progress for all of us. So, my mother knew that there was more to her story. I remember her countless times saying, always talking about the pressure in her head, so much pressure. She insisted that she had a pressure problem. She begged for a ventricular peritoneal shunt, a VP shunt, at one point in time. She begged for a vagal nerve stimulator. She knew there was something more to what was happening. And I remember her being so frustrated at the lack of answers, the lack of understanding, the lack of compassion, the stigma that she would be confronted with, particularly in an area geographically that is void of expert providers, female providers. Uh, you know, this is where we can acknowledge there is sometimes gender stereotypes and biases in healthcare. Women, when they present with complaints or concerns about their body, are more likely to be dismissed as having anxiety, as opposed to men who present with complaints. This is just fact. It's been proven. So, it is our duty to acknowledge biases and to attempt to restore balance in the system. Let me tell you this, first and foremost. This disease, it knows no gender. You can be male, female, non-binary, however you define. It can affect you and those you love. And that's what matters. We must create an open-minded forum where we can really talk about the real issues that affect our community so that we can mitigate the barriers to care. And my family experienced those barriers over the past 44 plus years, 50-something years. My mother would have been 50-something years old today, 50-something on loose count. So we know that, I witnessed my mother throughout her life. She was a intelligent, vibrant woman. She had many different jobs because oftentimes her disease would progress and she would have to take off from work and she would lose a job and have to go to another. And it's not because she lacked willpower or effort, it's because her disease was relapsing and remitting, similar to how patients with multiple sclerosis have relapsing and remitting problems that wax and wane. Disease exacerbation. Some may continue to worsen throughout time as they wax and wane. Others may remain at a kind of steady point. But over time, over the decades, it was clear that my mother had progressive disease. Gosh, there were times she was a seamstress. I remember she did the dress for one of the senators or the governor's wife for Bill Clinton's inaugural ball, and I remember watching the inaugural ball on TV, watching for her dress. I was so proud of my mother. Years later, she became a surgical technologist, and that's when I fell in love with healthcare. I remember learning with her, practicing with her. I would get to go to the hospital when she was on call, and she would be called into work overnight, and I would wait in the doctor's lounge and get to wear scrubs. I thought I was so special and important. I was so proud of her. Years later, she became a flight attendant. Wasn't long before she couldn't handle the flights, which she would have severe headache exacerbation with altitude gain. We'll talk more about that in episodes to come. There is a physiological reason this happens in patients with headache, migraine, and intracranial pressure disorders. She was then, after that, she became a manager for Isaac Hayes in his kitchens in Memphis, in his studio there. But every time she would rise, she would later fall because something was changing and progressing in her body, and we didn't quite have a handle on what it was or even realize, because there's a stigma, some people back then, we thought, well, why can't she just buck up, Yeah, everybody has pain. You just have to try harder. Like all of these hurtful things that people hear when they have chronic pain conditions. And what you don't understand is if you were in that situation and could feel what they feel, you would not be saying these foolish things. And there's a reason why it happened. And it took me 30 plus years to learn that reason, but it's why I'm here today. Because now that I know and I experienced this for myself, I cannot look away. I cannot stop. I cannot stop shedding light. I must share what I've learned and I must help other people because there's a reason. And then there's also hope. There's a reason to have hope because things can get better. We wish to pause for a moment and thank you, our Neuro Network's listeners, for your time, attention, and support. We are so grateful for you. If you haven't done so, please follow us on our socials. That's Facebook, Instagram, LinkedIn, YouTube, TikTok, Reds. You can find all of those by visiting ourneuronetwork.org, where you'll also find our blog and additional free resources of support. We couldn't do it without you. So, unfortunately, I watched my mother progress over her 4 decades of life. Slowly but surely, she became this empty shell of the vibrant woman I know. She resembled someone almost with advanced Parkinson's disease at the end of her life. Her affect or her mood was flat. Her speech was very monotonous. She was very depressed all the time, with severe activity intolerance. Anytime she was upright, she would have problems with ambulating, with her coordination, with her headache, nausea, vomiting, her mood, fatigue, just soul-sucking fatigue. She would have confusion, be unable to remember her name, her age, her address. She would stutter. She would have more seizures. She would have wild autonomic abnormalities, hypertensive episodes. Everyone in her chart toward the end of her life, they would just repeat the same thing that she had the diagnosis we mentioned, but also that she had severe mental illness, mood disturbance and disorder. And in the 2 weeks prior to her death, she presented to the emergency department of her local hospital over 3 times with severe complaints of headache and a hypertensive emergency, meaning that her blood pressure was life-threateningly high. The doctor wrote that she had a developmental delay, infantile, with a childlike behavior. And the sad thing is that she had no such developmental delay. My mother, it mentioned that she had a low IQ. Can you imagine today an ER doctor determining what someone's IQ is? They don't have the time to do that. And you can never just assume that someone has a deficit of intellect before you exclude other causes. There are reasons why people present with neurological changes that affect their cognition, and some of them are acute. And some of them are acute on chronic or complex. And for my mother, that was that. She was suffering from an intracranial pressure crisis. And her neurological manifestations were a direct result of her disease process. She was not born with them. She was not born with a congenital developmental delay. She did not have a low IQ. She was the most brilliant woman I ever met. But because this provider misunderstood that and assumed otherwise, they did not look for other answers. My mother never got one CAT scan or brain image during those 3 visits to the ER prior to her death. And, by the time, I want to stop before I tell you the rest of the story here, because I need you to know that in the 6 years prior to this, I had decided I wanted to be a nurse. I decided to go into nursing because I could, within 2 years, start to work and be able to attain income, and that would help me be able to help my mother. And I decided, I'm going to study neuroscience because I want to learn more about what's happening to her, and that may help me help her. It may help me understand. I know there's something. I need some connections. There's more to the story. She had been told things like, there's no reason for your headache, which is wild to me looking back, because it's so clear radiographically that we miss so much, so much. Been told that there's no reason that her brain cyst had no association with her seizures. That's just completely false. As a neurocritical care provider, I am quite aware that that is inaccurate. But what, you know, I chalk those statements, those up to medical community's attempt to explain something they could not understand. And they try to provide false reassurance to someone, but they didn't understand. And, if you don't understand, it's okay. Just acknowledge that, say you don't know, but don't dismiss someone's questions or their concerns about their body, because I have learned more often than not that the patient is right. They know what is happening to their body. They can feel it. They know when something's wrong. They may lack the scientific understanding to explain it in the medical terms and provide the pathophysiology, but the patient is always right about what they feel. And it is our duty to honor that and listen. And, we can help them identify the reasons and attempt to provide solutions. But at the end of the day, we're all human, right? We're doing the very best we can. We must acknowledge our limitations and seek to break down the barriers that limit our understanding so that we can promote comfort and quality of life and dignity. So, in the 6 years prior to my mother's passing, I had gotten my associate's degree and had started practicing as a neuroscience nurse in Tennessee. I had begun travel nursing. I went to Johns Hopkins because I heard they were the best place for neurosciences back then, and they are one of the top. Yeah. And I just wanted to get my foot in the door. I started even on a regular med surg unit just to get close. And then 2008, traveled to Tucson, Arizona to help open the Carondelet Neurological Institute. And that is where I transitioned over into neurocritical care. And I started pursuing my bachelor's degree. And I became a certified neuroscience registered nurse and a stroke certified registered nurse by the American Association of Neuroscience Nurses. So I was well on my way to trying to understand everything, but I was so young and there was still so much I did not know. So at that time, I still very much felt like I was still just naive. But, one day in 2010, on June 1st, I woke up to a phone call that my mother had ended her life. And unfortunately, my mother's suicide was a cannonball I could see coming. I never knew when it was going to hit, but I knew it was coming. I didn't know what I could do to stop it, but I tried everything. We all tried everything, everyone that loved her. But see, there are things you do not know that take time to learn, and you cannot judge yourself for what you did not know at one time. You must give yourself the grace, love, and compassion that you seek from others. So my mother, she had mental health issues and experiences in addition to her medical illnesses that really impacted her resources and her resilience. And this podcast is not a place for me to tell all her secrets but it is a place for me to honor her and a place for me to share our story in hopes that it can help others. And in hopes that brings some light into what patients and families go through who have these conditions, the decades of gaslighting, misdiagnosis, misunderstanding, the lack of compassion that they suffer from. That's it. Further add insult to injury, the PTSD, the post-traumatic stress disorder that comes from navigating a complex and chronic illness that is not recognized, diagnosed, or seen. And I'm not complaining here about me right now. Please know I am very lucky. When it comes to me, I've had a far different experience than my mother, but it's because of her. It's because of what I learned. There's no way I would have known what I know if I had not seen what I seen. If I would not have gone to nursing school, if I would not have become a certified neuroscience nurse, drug certified registered nurse, all of the things I learned really helped me to get the full picture. I had to not only be a patient, but a family member and then a provider who understood these conditions or started to understand. So when my mother completed suicide, I felt like such a failure. I could not help the one person I wanted to help the most. What am I doing here? Can't even help the one person I wanted to help the most. And I tried to leave neuroscience for about a year and I could not stay away. I did a critical care float pool, but I couldn't stop thinking about it. And I knew, and it echoed in my head, the quote she would tell me, unless someone like you cares an awfully, awfully lot, nothing going to get better. It's not, it's not, it's not. That's from Dr. Seuss and the Lorax. Because before my mother passed, she would often tell me, "You're gonna figure this out, and you're gonna teach them, you're gonna tell them." And she would tell her doctors that I was a doctor. I was like, "Mom, I'm not a doctor, I'm a nurse." She's like, "You might as well be." And I thought that was so wild that she would say, I'm like, "Mom, you can't tell, you need to communicate the truth, we're trying to promote trust." And oh, me rationalizing with her during one of her exacerbations was somewhat times difficult because there was mood disturbance. She would be more impulsive, agitated. Oh, to say that with love and compassion because I have felt the same effects of being more impulsive and agitated during my intracranial pressure exacerbations. I'm aware of what happens. Um, so after her death, I could not stay away, and that's when I decided to go back and go to grad school, get my master's, and then my doctor of nursing practice to become adult gerontology acute care nurse practitioner. And I have since devoted myself mostly to neurovascular and neurocritical care in the acute care setting in hospital. And I did that until 2022 in December when I took the last medical leave for treatment of my disease. Because here we got to the pivotal point here. You know, I had started to develop headaches in 2008, but I didn't really think anything of them because everybody has headaches, right? Nope, 4% of the population does not. And we're studying them to learn how. These people can never have had a headache in their entire life. Maybe they can help others. But it's true, not everyone has a headache. It's not normal to have a daily headache. If you have a daily headache, you should consider if you have a headache, facial pain, or migraine disorder. It is not normal. So, I was used to everyone in my family having headaches. And there's a reason for that. I'll tell you about that as we go along. But I think my story is going to take a while to tell you in future episodes, but I'll try to summarize some of it here. I'd always felt different and had struggled with my weight throughout my childhood, with obesity, with my appetite, my ravenous appetite for everything food, books, anything I set my mind to. So you see, my curse was sometimes my blessing, such is often the case. But as I was pursuing my graduate degree, I began to struggle more with my headaches, and I became convinced that I might have a brain tumor because I would wake up with the most horrible headaches, pounding, ringing in my ears, nausea, vomiting, vertigo. Had an MRI thinking, I'm sure they're going to find a brain tumor. Nope, nothing. Everything was quote unquote normal. And adjusted my work schedule. You just adjust. After I graduated, I ended up taking my dream job in Honolulu, Hawaii as a neurocritical care nurse practitioner at Queen Cell Systems. Ah, it was such an amazing time. I learned and grew so much. I met some amazing colleagues, an amazing team. My family, my ohana, who have stood by me and been with me since 2015. It was after moving to Honolulu that I started noticing more problems with my weight, fatigue, my voice, with speaking, feeling like I was choking. I found a large mass in my neck, ended up doing an ultrasound on that at work in the middle of the night with a little point of care ultrasound and concluding I think I had thyroid cancer. Sure enough, I did. It was poorly differentiated thyroid cancer with angioinvasion, meaning that it invaded my vessels in my neck. That is a sinister diagnosis to get. 50% 5-year survival rate. If it is metastasized, you were surely a goner back then. I started bracing myself for death that, oh, I see how this is going to end. Even though I put on a front and tried to fake optimism and hope, back in my mind, I was sure I was a goner because of all of the signs I had seen, the vascularity, the rapid vocal changes. I knew that this tumor didn't secrete the normal, it may not secrete the normal indicators for tumor. like thyroglobulin or antithyroglobulin. It may not even be responsive to radioactive iodine. The surest you can get is surgical excision of it. So I had surgery to remove my thyroid in uh, stages because initially we didn't know it was so malignant. The initial biopsy was inconclusive, and I was even offered that, oh, we can monitor it. But I said, no, I think this needs to come out. Something is not right. I don't feel right. And I'm so glad that I made that decision because if I had waited, I might not be here today. So at the time of my cancer diagnosis, I weighed 338 pounds. That's how much I struggled with my obesity. I was so hypothyroid, I didn't realize, that makes it easy for you to gain weight. I had problems with my autonomic nervous system and dysautonomia, meaning my blood pressure was sky high, especially my diastolic or the lower number. I was tachycardic with like postural orthostatic tachycardia syndrome or elevated heart rate when I was upright. Had problems with sweating, so much sweating, and temperature regulation, sleep, awake, thirst, all of the like major functions of life, right? This is talking about your autonomic nervous system. A lot of the things I'm mentioning are controlled by your hypothalamus in the brain, your thermostat. It seems like my thermostat was broke. My thermostat controlled all of my hormones. And when you have those things going haywire with inflammation, it's like a cascade, an immune cascade, a neurological cascade. I began having brain fog and severe headaches, just worsening, worsening, worsening. I woke up after my treatment for cancer on April Fool's Day, 2017, with a right facial nerve palsy, meaning my face was completely paralyzed on the right side. I thought, oh my goodness, it's in my brain. I've got mets in my brain. I'm dead. Then I proceeded to make a series of unfortunate life decisions. And I struggled. It was a hard time because my brain was changing, my body was changing. I didn't know what was happening. It was so scary for everyone that loved me. Then it became clear to me. I started having balance problems with my cognition and my gait and stuttering. Like I almost started to seem exactly like my mother, like a spitting image. And it dawned on me, oh my God, it's happening to you. You watched it happen to her, and now it's happening to you. And the problem is you don't know what happened to her yet. So how are you going to stop it? And what are you going to do? Where do you start? I tried. I sought help from everywhere. Rheumatology, endocrinology, neurology. I became convinced one day, oh, I think I had thoracic outlet syndrome because I had all the symptoms of thoracic outlet syndrome and dilated vessels in my head, neck, and chest, and arm pain and weakness with use of my arms. All of that worsened my headache. I had pulsus paradoxus. I had certain tests with the, uh, that you do for thoracic outlets, turn up positive. My initial test, they said, yeah, you've got some vein occlusion there in your subclavian veins, but that's all been benign and we don't think it's a problem. It's like, how can you say it's there but it's not a problem? I'm presenting with this problem. I was dismissed at first. And so, after going to doctor after doctor, and you yourself are a neuroscience expert and you can't explain things, you start to think like, oh, they started asking, well, you've gone through a lot. Maybe you need to see a psychiatrist, psychologist. This is stressful. You could have anxiety. I'm like, no shit. It is stressful. I should see a psychiatrist, psychologist. Thank you. I'll take a referral. And I did that. And I tried to make sure that I was taking good care of my mental health because this disease affects your mental health. Whether or not you want to acknowledge it or not, it does. And most of us who have it, we acknowledge it. So for about 2 years, I stopped seeking answers from the healthcare system. I hired a personal trainer. I focused on doing everything possible I could to control my health, advocate for my health metabolically, to minimize my risk factors for malignancy and obesity. I lost what is today over 180 pounds, and still my disease progressed. Finally, one day, as I was having problems walking and talking, and I had severe vertigo and nystagmus where your eyes shake when you move them, I called my friend and I said, I think I have to go into the ER. Do you think this is smart? And my friend told me, you look like shit. You need to get there like yesterday. This is not the person I know. I'm so grateful for my friends who were honest because they empowered me to seek help again after, being turned away, not misunderstood, not misdiagnosed, just not seen. We just didn't know before. But the day I went back into the ER in 2022, February, I met my disease expert, Dr. Ferdinand Hui, here in Honolulu, Hawaii, who had just relocated from Johns Hopkins, wouldn't you know? And he is one of the neurointerventionists, one of the most respected in the country. And he's one of the leading experts in cerebral, venous, and CSF disorders. I'm so grateful for the day I met Dr. Hui because it was him who first diagnosed me with cerebral venous congestion and intracranial hypertension. I had suspected that I had a jugular venous occlusion and stenosis problem based on my images I had seen and looked at, noticed quite severe narrowing of my jugular veins, and I was having such symptoms that correlated with the jugular vein and the cranial nerves that surround it, the vagus nerve, you know, the facial nerve, the spinal accessory nerve, all of the cranial nerves of the jugular foramen. And, those are localizing signs, what we say in neurology, meaning that if you're having signs in your body that correlate to one anatomical spot, then you need to look carefully and closely at that anatomical spot on imaging. When I did that, I saw this clear and overt jugular venous stenosis. So I thought, could this be causing my problem? And I went to ear, nose, and throat experts, some of the leading in the country, who specialize in the facial nerve and things, concerned that I had what we called Eagle syndrome. I was told that, no, this is not the case. You're way off. You know, you just have TMJ. I was like, what? Doesn't sound right. I felt dismissed. Uh, we'll talk more about that later. But with Dr. Hui, I finally had answers in a diagnosis. And he told me that I see this in families, in patients with mixed connective tissue disorders and hypermobility. And I was very hypermobile, very flexible. Had many mixed connective tissue issues, repeated strains, sprains, dislocations, bruising, all of these things, poor wound healing, keloid scars, allergic issues, problems with immune responses. And all of these things started to be like overlapping features that we see in patients with cerebral venous congestion, intracranial hypertension, or high brain pressures. So, Dr. Hui said, we see this in families, and I suspect that it affected your mother. And in an instant, like I was just like, whoa, this is what I was suspecting. This is what I thought. Nobody believed me. Everybody thought I was crazy. I thought, that it was all in my head. But here is an expert telling me that I'm not crazy. So, and that there's a reason for what I feel, and that other people have felt it too. And I could, when you search for 12 plus 14 years, I was searching for answers. When you search for answers for 14 years, and then you finally get them, and it explains everything. That is just a wild experience, and I'm so grateful for it because many patients don't get that. They're gaslit, and they don't, it, not intentionally for the most part. I don't think providers intentionally do it, but until I realized where the gaps were, I never would have realized how vulnerable patients were to gaslighting. We have to acknowledge our humanity, that science is just progressing. There are things we're still learning, you know. So fast forward, my journey with cerebral venous congestion, intracranial hypertension, and also intracranial hypotension from cranial CSF leaks. I've had so many procedures and surgeries, diagnostics. Not all of them probably were they necessary throughout my lifetime, but hey, it takes a journey to learn these things. I've had bilateral subclavian vein decompression, where my first rib in my anterior scalene was removed to relieve compression of my subclavian vein. I've had bilateral internal jugular vein decompression to remove the styloid process from the skull and the muscular compression that was compressing my jugular vein and my cranial nerves, including my facial nerve that had been eroded by the jugular vein that had become so enlarged and engorged at the top that it had eroded the skull base and was compressing my facial nerve, just like I said it was. I just want to mention. So experts can be wrong. Doctors can be wrong. We must not acknowledge that. We also must acknowledge that patients can be wrong, but no one's intentionally wrong, right? We're all doing our best. So I want this space to feel safe to discuss where we are, where we've been, where we hope to go, without blame, because we need all our providers. We need all the help we can get, and we need to band together, because if things are going to get better, it's going to take our work and effort and collaboration as patients, providers, and experts. So, and then subsequently, I also had bilateral internal jugular vein stents. I've had 2 cranial CSF leak repairs. And currently, right now, I still have an active cranial CSF leak because I have underlying intracranial hypertension from persistent venous congestion. I still have left renal vein compression and/or nutcracker syndrome and left iliac vein compression. I'll probably be having further diagnostics and treatment of that here soon in Denver, possibly iliac vein stenting. There may be treatment involved for my renal vein at some point in time. And then ultimately have my skull base repaired one more time in hopes that my CSF leak will seal and not return. The goal with the venous interventions is to decompress and unburden the venous system so that it can do its job of balancing and helping with intracranial pressure and CSF pressure. Because when the venous system is burdened, your helper is burdened, and the pressure changes. The body can no longer mitigate the pressure changes that happen with normal activity. And for many of us suffering from this problem, it's not just because the veins are compressed. There's a reason the veins are compressed. There is a metabolic, cellular, immunologic reason the veins are compressed for many patients. And you can have patients with venous compressions that are not symptomatic with these disorders. You can see some of this in the normal population. So not everyone with a venous compression has these disorders. And so what we must be careful, we can't say that everyone that has what appears to be an occlusion has this disease. You may mistreat people. But what we must really listen to is the story of the patient, their symptoms. What are the physical findings? What do those focal and local findings support? Are there things here? And do those things correlate anatomically to neuroanatomy and certain systems? Can you put together the pieces of the puzzle in a scientific and evidence-based way? And for many patients, yes, you can. But the medical system has not had the luxury, the time, it hasn't created the space to really do that. You can't do these things in 20 minutes and 30 minutes. This takes specialty care across many disciplines. It takes, the effort and the extent I have had to go to as a patient to coordinate my care is just insane to me. And I don't understand how anyone who is not a medical professional could navigate the system. It has been hard. And it especially is hard when you have cognitive difficulties, right? To use a system that is declining, to advocate for your system that is declining, it's quite a hard task to do. And that is why we must acknowledge when we need help. And do not be afraid to go to the ER. Do not be afraid to tell your doctors, I am suffering. I am suffering. The problem for many patients is they ask for help and then they don't get answers and they stop asking. And unfortunately for some of us, too many, they cannot take the pain, the burden, and they may resort to measures like suicide. It is my hope that this podcast and everything I do in life from here on out helps to address that problem. I don't want any other daughter to lose their mother to suicide from this disease. I don't want any other patient to feel inspired to take those steps because there is a better alternative. We do not need to die by traumatic means. There is a way to promote our dignity, to ease our suffering, to promote our quality of life. We must have a place where patients can go and get the help they need to be heard with love and compassion and support. We must allow them access to palliative treatments that promote their dignity and quality of life, even if those treatments are not totally curative. That's the definition of palliative, to palliate. And we do not have to know everything to help. We don't have to know everything to acknowledge suffering. And we can use science and evidence and to offer treatment, but we can also use our hearts and our compassion to not limit that treatment or access to treatment just because there is still yet things to learn. We must also protect patients so that they are not taking risk with the procedures that are not evidence-based or have or are done by inexperienced providers who can harm them. We must help educate other providers so that they have access to the knowledge, training, and support necessary to care for these patients. We need helpers everywhere. So there's so much work to do for us, but the work is so incredibly worth doing and important because I can tell you this, the quality of my life today compared to 2016 is a night and day difference. I am so grateful to be alive. I am so grateful I am here. My pain, it's nothing like it was. I understand what's happening to my body and why. I understand the molecular, the immunological reasons, the genetic reasons, because I'll tell you this, I did learn. We got that consult. Finally, it took me, I don't know how many years to ask for a genetics consult, even though all along I was telling people this is genetic, this happened to my mother. I didn't actually have the courage to muster up and say, can I have a genetics consult until a year or so in to my journey with Dr. Hui. And of course, he gave it to me right away. And I came back after that consult with results showing that I had an autosomal dominant, meaning that 50% chance of passing this on to my offspring, and then it came from my mother. Autosomal dominant melanocortin-4 receptor deficiency. What the hell is that, you say? Well, the melanocortin-4 receptor predominantly lives in the hypothalamus, wouldn't you know? The hypothalamus. Remember that word? That's the same word I said earlier, where my thermostats broke. Ding, ding, ding. That's a big clue. The hypothalamus. Hey, that's the thing my mother wrote about in her journal and taught me. She taught me what that word meant. She told me that her hypothalamus was broken. So you're telling me my mother knew what was happening to her body before science really connected the dots? Yes, I'm telling you that. It's true. My mother was so right about everything. even the things she was told she was wrong about. And for so long, I was so angry at the medical system and the doctors who didn't see it or who gaslit her because she fell through the cracks. She should have had a CAT scan. She should have had her ophthalmic pressures checked. She should have had a lumbar puncture. She probably should have had a BP shunt. That was a treatment available for her back then because you know what? After she died, Dr. Hui, we went back and looked at my mother's images and we could see clear signs of years of progressive disease. The backs of her eyes were flattened from the high pressures inside her brain. Her cerebellar tonsils of the brain, that part of her brain, the cerebellum, was hanging down through the foramen magnum or the hole in the brain, resembling a Chiari malformation. We call it cerebellar tonsillar ectopia. For some patients, they're born with that. For others, it's acquired. And for patients with intracranial hypertension, this can happen as the brain pressure builds. It pushes the bottom of the brain out of the bottom of the skull, causing vision, hearing, balance disturbance like my mother had. And also, through the years, it's high pressure, it erodes the skull base. It creates holes or defects in the dura that lines the brain and then also the skull. And then you start to lose spinal fluid. Well, there's only so much spinal fluid you can lose before you start to feel bad from low pressure, and ultimately, ideally, the brain needs to be in a vacuum, a closed space for the pressures to maintain balance, and everything needs to work kind of optimally to keep them there. But for some of us patients, if we have a broken thermostat or an altered cellular, metabolic, or immunological reason that things are going haywire, the picture could be much more complex. And it's our job as providers and as healthcare team to figure out where is it broken and what started what first. And we do our best, but we are limited. There is so much to know. So I share with you what I've learned, and I tell you, there is much more to learn. Please know that I also may be wrong about things that I share with great conviction, but I have done my due diligence to be evidence-based, and I'll acknowledge my limitations when I see them. And I trust that if anybody out there listening, any expert as you listen along, if you ever hear something that doesn't sound right or you think may be better explained, please let me know. Because I acknowledge too, there are many times in my disease I thought I was right when I learned I was wrong. I've been humbled so many times as a patient, as a provider. This disease has been the most humbling disease, and especially as a daughter. Can you imagine all that I wish I'd done for my mother now that I know better? So many things. And I'm going to tell you about every single one of them because I want things to be better for your mother, for your daughter, for your patients. So the melanocortin-4 receptor, it is located not just in the hypothalamus, but throughout the autonomic nervous system, the very nervous system that was dysfunctional within me. It is responsible for peptide signaling, glucose signaling, insulin homeostasis. It controls appetite, hunger, satiety, thirst, urination, sleep-wake cycle, and sexual function. The hypothalamic pituitary axis, hormones, all of these things I had problems with on some level, appetite. Because when the melanocortin-4 receptor functions appropriately, well, when you're hungry, you eat. And then the receptor says, that's good, I'm satiated. When the receptor binds to alpha melanocyte stimulating hormone or alpha MSH, that's what happens. It says, I'm hungry, I'm satiated now. I don't need to be inflamed. Everything can work appropriately. Body, here's your good stuff, anti-inflammatory stuff. Insulin glucose does what it's supposed to do. Everything's balanced. Everybody's at peace. But when it doesn't bind, when your melanocortin-4 receptor cannot bind to alpha MSH appropriately, such as that, which happens with melanocortin-4 receptor deficiency that runs in my family, even if you eat, you're never satiated. You don't ever feel full. You just get more hungry. Your insulin level goes so high. My insulin level is the highest my endocrinologist ever seen, nearly 500. Well, that for me, that triggered because the MC4R receptor controls your thyrotropin release hormone. You can get hypothyroid with it, and then high insulin levels and all of the cellular changes that come with it that are toxic and inflammatory that can predispose someone for malignancy, obesity, venous compressions when you have increased bone, muscle, and adipose tissue. Then you get altered mast cell function because the melanocortin-4 receptor controls mast cells. So you get mast cell activation disorders and similar things. You get peripheral nerve palsies like facial nerve palsy, cranial nerve palsies because patients with this disorder are at risk for cranial nerve compression because of the inflammatory changes. And we also know that patients after traumatic brain injury, if we measure alpha MSH levels in the brain, and we've noticed that some patients with abnormal alpha MSH levels, they have intracranial hypertension after traumatic brain injury and suffer more so. Those patients are often, they may have metabolic dysfunction, type 2 diabetes, that sort of thing. So we know that this system and the peptides involved in the disruption of it can contribute to intracranial pressure disorders. So for me and my family, melanocortin-4 receptor deficiency caused hypothalamic obesity, intracranial hypertension, cerebral venous congestion, recurrent cranial nerve palsies, intracranial hypotension, recurrent CSF leaks, and did I say multiple venous compressions? Hypermobile mixed connective tissue disease resembling hypermobile Ehlers-Danlos syndrome. And, my mother and I were not the only ones in my family. There are numerous others. And it's not my job to share their story, but I can't help but acknowledge our truth because I know that we are not alone. I know there are other families like us. There's actually 1 in 500 people can carry MC4R deficiency. And when you see, not just carry, you have it. If you have one copy of one gene, you have it. So that's quite a lot of people. And you know what? Everyone has melanocortin-4 receptors that can be offended and work less optimally. With age and obesity are MC4R receptors, no matter who you are, because they function less optimally. That is why I believe patients with intracranial hypertension often have metabolic syndrome features, features that are consistent with MC4R pathway disruption. Because the cellular pathway of MC4R is not just one gene, it's multiple. And it gets complex, but when you realize how it's all connected, you start to see the bigger picture. And you realize, hey, these patients aren't crazy. If your vagus nerve doesn't work, you are anxious because your vagus nerve is responsible for activating your parasympathetic nervous system, which is supposed to keep me calm. So if my right vagus nerve is partially paralyzed, it makes sense that my heart rate is through the roof and that I'm anxious with stress and stimuli because my vagus nerve is running at half capacity. I do not have a problem with anxiety. I have a problem with my vagus nerve, my autonomic nervous system. So it has the manifestations of anxiety, but you know what I have found empowering as a patient? By understanding this, I have learned how to master my vagus nerve. I learned how to meditate, how to breathe deeply, how to become less type A. I learned how to do vagal nerve stimulation, how to promote sleep, wake, balance, and health. So slowly but surely, I realized for me where the problem was, and it was at a cellular level. And I realized that I must do everything possible to help myself. And over the past few years, I've done that. Revolutionized my diet, do an anti-inflammatory, a ketogenic diet for me was the one thing that really helped me because prior to transitioning, I had hypoglycemic unawareness, meaning that my blood sugar was dropping down to the 30s and 40s during my episodes, and I had never known it throughout my whole life. And that was precipitating a lot of my hunger and a lot of my neurological symptoms. If you're hypoglycemic, your facial nerve, well, it needs a lot of ATP to work. Can you imagine what it does when it doesn't when your blood sugar's 30? Yeah, it's going to be partially paralyzed, and so is the rest of your body if you don't fix that. You get it? So here, for me, though many patients and many of us focus on venous compressions, we focus on the physical signs of our disease and findings. I really want to encourage us to look deeper at the cellular, immunologic, the genetic reasons and how they overlap. Metabolic diseases are trigger the main causes of death in the United States. Stroke, heart disease, diabetes, cancer are all consequences of metabolic disease. So since transitioning to a ketogenic diet, my hypoglycemia has resolved. My brain has now a more stable supply of ATP. I'm no longer hypoglycemic like I was, and I'm feeling a lot better. I still have a disease that I still have a melanocortin-4 receptor deficiency, but I help my MC4Rs work more optimally by maintaining a ketogenic diet. Is a ketogenic diet the answer for everyone? No, not saying that. Because each patient deserves individualized attention, an objective assessment, because just because we have similar problems doesn't mean we have the exact same problems, and we must be careful to not make leaps and bounds. This can get complex. I know, but I do know now that I really look back at it all. It makes so much sense to me now that I understand more, and I've gone through this, and I'm so grateful to be alive and to be here and to be sharing all of this with you. And I'm so excited because I'm getting better. I'm coming back to life. I am now, though I'm still navigating treatment, I'm optimistic that I'm going to be returning to practice. And that's this podcast is one of my first steps toward returning to work again. Eventually, once my treatment is complete, I will be offering coaching and consulting to patients with neurometabolic, cerebral, venous, and CSF variations. And I'll also be offering telehealth care services to patients in Arizona and Hawaii with eventual plan to expand to other states because I really want to help create a system of care that helps patients and families like my own traverse a system to coordinate transitions of care, to help them have access to support and treatment that optimizes their quality of life while they navigate the system that can take years, because there's a shortage of providers. We need more specialty providers for us. We want to focus on headache and facial pain management, quality of life measures. So there's much work to do. And this podcast is the beginning of it. And I hope that you'll join me. Thank you, our Neuro Network, for joining us for our first episode. It was longer than I anticipated, but our stories take time, don't they? And that is why it is difficult for many of us to navigate the system, because the system is not designed to provide time for our stories. But I believe that progress will be made by giving space and time and attention to our stories. And I want Ohanamana Network podcast to be a forum where we learn and hear one another's stories, and that we use that knowledge, information to serve our greater good. I'm convinced that the patients and their families hold the keys to greater understanding. I learn the most by spending time with a patient at the bedside. One of my favorite things to do as a neurocritical care nurse practitioner was just to go be with and assess the patient, to spend time with them, to watch them. That everything is communication, not just what they're saying, but their vital signs, their heart rate, their temperature, their sweating, like everything is all this information. And I use that to really get a picture. But really, their words, if they have the ability to provide them to you, and what they say can be so informative and helpful and necessary. And we must start there with the stories. And so as we go forward, we'll discuss many names and labels given to our variations and parts. We'll hear many stories throughout the seasons ahead. And we network together, know that, because we recognize that we cannot heal our parts in isolation, and we cannot heal our bodies as isolated parts. We can't heal our stories, our families, or our hanas as isolated persons. We must learn and honor these systems, our variations, how they're intricately interconnected and alive today if we wish to attain and maintain homeostasis for a greater good tomorrow. And that's one goal of the Ohanamana Network. We wish to connect and honor patients, advocates, and experts as one Ohana. To do this, it helps us we're on the same page. We are, after all, on the same team. It's not us versus them, patients and advocates versus experts. We're one. We must communicate as one to assure our homeostasis and longevity. So please stay tuned next week and those to come with more stories of honor, hope, and homeostasis from our Ohana. Thank you, Ohanamana Network, for joining me. I'm honored to walk this path with you and excited for the knowledge we will grow and the places we will go together. Know I care deeply for you and that you're not alone. There are many of us patients, caregivers, and experts around the world who see you, who love you, who want for you freedom from suffering and a life of peace, happiness, and homeostasis. This was possible for me, and I believe it's possible for you. It may take us time, but I believe in the limitless potential of our collective healing as one. That concludes our podcast for today. Thank you again, our Neuro Network, for joining us. Together, we are more present, informed, educated, wiser, and empowered to advocate for our own personal health and that of our community. Please join us again next week for our next episode with more stories and insights from our community. Meanwhile, please walk gently, breathe mindfully, and know you are loved and supported by all of us throughout our Neuro Network. See you next week.